the book.
But see, they can have things like this because they have, you know, a universal health system, whereas we don't.
That's right.
So actually, America, we're not allowed to have these delicious snacks because we don't have a universal health system. So if you want the delicious snacks, that is this lovely British thing I'm eating, then we have to have AB 1400.
Especially given our insulin prices, right?
Right. Given our insulin prices right now.
Yeah. So 1 minute to 5, but we will start at 5. Ooh, 5. I do have, let's see, share thing.
Where we shall be talking about the insurance menace.
That Bronwyn, are you out there?
Bronwyn, you're amazing.
Bronwyn, yeah.
Bronwyn is an amazing human.
Her own kind of Jedi.
She is. She is our graphics Jedi. She manipulates you with the power of her artistic abilities.
Force.
Yeah, that's her force. Art is her force.
Her force.
And she has the cutest little tiny dog that I want to adopt. It's my little pet dog.
So it's 5, and in 5 minutes we'll be rolling with the 21st episode of AB1400 CalCare Office Hours. So welcome to everybody's here. Dr.
We're
Bill,
legal. We can have alcohol now.
yeah.
We're 21. We've had 21 office hours. So now we can have, we can make this a happy hour.
Yeah. Blackjack, 21.
Right. Even though that's another reason why we have to pass AB 1400 is because, you know, we cannot have all these sweets and alcohol and not have a universal health system.
Right. We need to be able to treat mental health things like gambling addiction. People can't stop playing blackjack.
Substance abuse.
Substance abuse.
Addictive to British treats like I am right now.
Welcome, Dr. Bill.
Bill.
Hello. Greetings. May the force be with us.
May the force be with us.
I think we should keep going with this one for like a couple,
And maybe we'll switch it up, and maybe we'll, for our Trekkies out there, maybe we'll do some Star Trek stuff a little bit later, because I have mentioned AB 1400 being the Starship Enterprise. So maybe we will live well and prosper in our next round. For all my Trekkies out there.
I look a little like Spock.
Oh, look.
What you got?
Paul is ready to go with the gear for when we do a Star Trek type.
Oh, he's got the pin.
Beam me up, Scotty.
Got the communicator. Sweet. I want one of those little Baby Yoda statues like Congressmember Lou has on his. It's got those bookshelves with all those impressive law library books, and then he's got a little Baby Yoda sitting right there with all his law books. I'm like,
hey, I see Michael. We're starting in a couple minutes, but you have your hand up, Michael. Is there a? Oh. Actually, well, we'll go over the agenda in 2 minutes, but the agenda is it's really short. It's simple. It's a 2-hour time. And by the way, you're welcome to stay as long as you want or short as you want. But here's the agenda, just so you know. We say a little bit about AB 1400 in general, and then we open things for questions. That's the agenda.
It's office hours, just like in college. Like you would go to the professor's office if you have a question, get your question answered. And you don't have to stay. We're just here out of a labor of love to provide a place for people to come and ask questions about this bill. We have some very good discussions about single payer healthcare as a whole, potential strategies, and then we bring it back to what the bill is, and we try to tie in as much as we possibly know with the bill. And like I said, this is kind of like a each one, reach one, you take what you learn, you go back to your community and, share it there. We're trying to get this be kind of like a echo chamber, or not an echo chamber, like a megaphone actually, to make, knowledge about AB 1400 more out there in the community. We've been on this obviously for 21 weeks now, and that's 4 or 5 months, and that's actually ahead of basically everyone else. So but things are ramping up, and CNA is firing up, and as we get ready to head into the fall, because we're already mid-August, which is amazing, as we head into the fall and winter, you will see a lot more coming about AB 1400, but always remember that you heard it here first. And this will be kind of a ground foundation, but we are close with CNA and other organizations who are working on AB 1400. This was just created as a home base.
Yeah, so we're at 5:05, so we'll officially launch our starship here. So this is AB 1400 Office Hours, the 21st edition, where we will take on the insurance menace. So this is hosted by, or a joint production of two organizations, Healthcare for All Los Angeles, Physicians for a National Health Program, Southern California. The backdrop of the whole story is that in February of this same year, a group of rebel nurses known as the CNA introduced by a few legislators in the California legislature a new single payer bill, AB 1400, to do single payer in California. And so the purpose of Office Hours is to say a little bit about the bill and then answer a lot of questions about the bill. And so that is what we are going to do. And we are here on Zoom, and we're also live on Facebook Live. And so for everybody who's out there, welcome. And let me, Jean, do you want to do the little like
intro to CalCare?
Yeah.
All right, let's do an intro to CalCare, just because we have some new names here. And so welcome to everyone who is joining us, who is new, who hasn't joined Office Hours before. Maybe you were watching along on Facebook and decided to pop into the Zoom room. Welcome, it is all love. We are here to help you. But let's go over, what is this thing that we keep talking about called CalCare or AB 1400? They're kind of synonyms, we use them interchangeably. So CalCare, and I have to do my shout out. Thank you to CNA for this graphic. I have read it so many times, but it is so helpful because I cannot memorize this all. So they have created this one sheeter that is just excellent if you are, talking to other people in the community and you do not want to go into all 60 something pages of this bill. This is basically what it is. So CalCare is also called the AB 1400, AKA the California Guaranteed Healthcare for All. It is the solution to a broken healthcare system. It guarantees healthcare as a human right in the state of California by providing a comprehensive, high-quality healthcare to all, just like Medicare for All would do for us nationally. It provides universal coverage, and we're talking about everybody in, nobody out. And we mean everybody, regardless of your race, sex, gender, country of origin, disability status, immigration status. And immigration status has come up in a couple of conversations I've had in this past week, where people who are who do not have a full immigration status yet are concerned that they may not be included in this. But guess what? Yes, you are. Marital status, age, and income, you get the care that you need regardless of the ability to pay. We'll talk about pay a little bit later, because that is the biggest question everybody asks. Well, how are we going to pay for it? And I have a few cynical responses, but none of them are appropriate for right now. There is a single public program. So instead of having the gazillion payers, Dr. Bill has a lovely graphic of this. I call it the spaghetti bowl. It's a single payer, publicly funded through progressive taxation. And what does that mean? That means that if someone's a billionaire, people who own certain companies that were named after certain rainforests, they may pay their taxes at a higher rate than you and I. Why? Because, well, they're billionaires and you and I aren't. If you are a billionaire, feel free to contribute to our cause. I would really appreciate it. And there will still be love for you there. But I don't think any of us are billionaires. But if you are, I'm happy for you. And so it will cover the necessary care here in California, eliminating billions in bloat and waste and saving people thousands on their healthcare costs. The bloat and waste is a lot of that time that people spend having to chase down claims, do these things that they think makes this healthcare system more quote unquote effective and quote unquote cost effective. But actually it is, you know, you're paying people more than minimum wage, trust me, to sit on the phone for 30 or 40 minutes with health plans just to answer one simple question. And so that translates to higher premium costs for you as well. So that's where this will save you, thousands in healthcare costs, because you will not continue to be jacked up with your premium costs. And trust me, after this pandemic, health plans are salivating to jack up these premium costs if they haven't started already. Okay. Fully comprehensive benefits. Now, this is where I say this is Medicare for all on steroids. This includes medical, dental, hearing, vision, mental health, very important, prescription drugs, long-term care, even more important, and more. All decisions about your care will be made between you and your doctors or nurses, not the insurance companies. And once again, the insurance company is not a healthcare provider. Okay, they are a regulator of health services. So I just want to emphasize this. A health insurance company, since we're talking about the insurance menace, this is our theme, is not a provider. A provider is a physician. A provider is your nurse practitioner, your nurse. A provider is someone who is providing you that care, providing you that medication, that therapy, something of that sort. A CNA who's getting you up out of bed to take you to the bathroom. That is a provider. They're providing you that service of assisting you to the bathroom. Guess what the insurance company is not doing? None of that. So they are not a provider. They are a regulator. I like to call them a faucet, and trust me, they keep their faucets turned really tight. And so anyway, I digress. We're going to talk about more so why fully comprehensive benefits, this is Medicare on steroids, because Medicare typically does not cover the dental, the hearing, the vision part of it, or the long-term care. And so by providing this, we are going to save money because people will get the care that they need when they need it, not when it's so bad they've got to go spend thousands and thousands extra in the hospital because they had to get sicker than they needed to be. Freedom to choose your care provider. Ooh, this is important. Most people be like, well, I like my insurance. Do you really? Or do you like the doctor that is covered under your insurance? And for those of you who do like your doctor, that's fantastic. But there are plenty of you out there who don't. And so, but you do not have the freedom to choose another provider because you can't, you're stuck within your network. You might be stuck within your HMO. And so under CalCare, there will be no more in-network, out-of-network, and you will have the freedom to choose any doctor or hospital you like. What does that mean, Gina? That means that you find a friend or a family member recommends a doctor, says, hey, my doctor's really great. You should check them out. You should be like, oh, okay, great. You call their office. Hi, I would like to see if such and such doctor is available to see new patients. Oh, great, they are. Do you take CalCare? Fantastic. When can I set up an appointment? You arrive at that appointment and you have a seat and you get wait to see your doctor. That is what I mean when I say freedom to choose your care provider. No more, do you take Anthem? Are you a network? Are you an in-tier provider? Are you a first-tier provider? No more of that. Goes away. It's great. Free at the point of service. So no more copays, premiums, or deductibles. You arrive at the doctor's office that you just chose because your friend recommended them. You show them your CalCare card. They give you those new patient papers and you have a seat. And that's that. It is really that simple. And then a just transition. So what about the people who currently work in the industry, the insurance industries? Well, you're right. What about them? That is important because they should not have to suffer due to the malicious and bad leadership of these companies and these practices that have been going on for decades, right? So that's why written in this bill is funding and programs to protect and support displaced workers in the insurance industry. Will some of these jobs go away? That is absolutely true. We're not going to sugarcoat that. But will there be some support for the people? Yes. And that is what I like about AB 1400. Lastly, we're talking patient care based on patient need. No more financial incentives to avoid providing necessary care. Well, Gina, isn't that illegal? Yes, it is. It is absolutely illegal. But how do they get around that? Well, we all know about loopholes. Loopholes meaning that they have certain in-tier providers, certain capitated providers that may be overwhelmed, may not be able to see you when you should be seen. And so you get put into a long queue. You don't get the care that you need when you need it. And all of this is legal, by the way, but it is financially, it's sound for the insurance company because they've had a better contracted rate with those providers versus you going to another provider that might be able to see you when you need to be seen. So that's how they get around it. It's not necessarily breaking the law. It's just working the system, and they do it all the time. So ladies and gentlemen, that is AB 1400.
So that is fantastic as always. Thank you, Jedi Gina. And welcome everybody again. And we in a second will launch into questions, and questions can come on the chat, or often our fellow Jedi Paul Newman will often kind of keep his eyes on the chat in Facebook and see if there are any questions there. But I'll just say one thing in keeping with the theme, which is about the menace of insurance companies. And they are. I mean, they're you know, I as a physician, I just like judge stuff as whether it's, among other things, whether it's toxic to the people I take care of or not. And I think it's pretty clear to me that insurance companies are more or less toxic to the state of California and to patients in California. And I wouldn't sugarcoat that. They are a menace. So many stories on that front. But I see, let's see, a question from Michael of the owner of the iPhone, named Michael. Says, if clinical and hospital services are a provision of healthcare, then how does one explain the third highest cause of death in the United States, i.e. iatrogenic? Okay, so actually, I'm not, it's kind of a very general question. And I'm not sure if this is a question, well, about the bill, or if it is about other factors, which are that have to do with whether doctors and other healthcare providers sometimes kill people in what they do. So I'm gonna say, I guess I don't know the answer to that question, or not sure I can connect it directly, but I don't know. Dr. Bill, you have your hand up. Did you want to address that or another issue? And Michael, if at some point you want to follow up on that question, of course you can, please do.
Well, I wanted to say something else, but I will address that issue, and that is when you have the vampire in charge of the blood bank, when you have the fox in charge of the chicken coop, you know, how likely is it that the vampire is going to clean up their act, you know, after they make a big bloody mess, right? So, I mean, like when doctors, you know, in the hierarchy, in especially in larger institutions who are really in the manager class, are negotiating with administrators and insurance companies and all that stuff behind closed doors, they're not likely to clean up their act. So they are likely to cause iatrogenic, meaning hospital or industry related death and disability, you know, causes of the system to perform poorly, right? They're not going to police themselves, that's for sure. And maybe to tie that in, I mean, Gina likes to call this chart the spaghetti chart. I call it the flying spaghetti monster, but it's really how we pay for healthcare in this country, according to our friend Henry Broska, a health systems expert. Every one of these little boxes, hopefully you can see that over my picture here, my background, but every one of those little boxes, the lines that connect them are real agencies. And then when you look at the Canadian system, which is a real single payer system, I mean, it looks like what you would want out of a system, which is, a nice kind of algorithm, a flow chart of payment, right? So it's all clear, it's basic, it's standardized and transparent, unlike that flying spaghetti monster that we have. I mean, maybe that makes it too cute to call it that, but it is not just administrative waste, but it's an opportunity for fraud and abuse. And I wanted to point out that President Biden this week announced his proposal for Medicare price negotiations, and in doing so, he prefaced it by saying that big pharma, not just big insurance, but big pharma has priced their products based on what the market will allow, right? We've all heard that term. It's based on what the market will allow. Well, what does that mean? That means there's winners and losers in a market. And, I think Gina said this, it's just not right to price healthcare based on markets where people's needs are not met. And good on you, President Biden, for pointing that out this week. But good on us for pushing this issue so hard that even President Biden now is saying the same thing. So the insurance companies do the same thing as well. They price their product, which is really a non-product. I don't even call them the insurance industry. They're not really an industry. Industries make things. Insurance doesn't make anything. It acts as a risk pool, which we could do, and the government already does in a lot of instances. So we need to act as our own risk pool and not leave it up to these commercial entities like health insurance. Because when you do leave it up to them, you get this, which is waste, fraud, and abuse. And you get our system, which fails miserably. We are the gold medal winners of COVID-19 deaths in the world. We have more COVID-19, even though we're by far not the largest populated country in the world. We still have the most COVID deaths, and it's because of this. And we need to look at that as what would get us out of this mess, is to get rid of this bogus system that we have for paying for healthcare. And then guess what? We could do as well, or at least as all the other advanced countries in the world when it comes to public health emergencies like we're dealing with now. Thank you.
Thanks, Dr. Bill.
Yeah.
I just want to go, I see some things in the chat. Going on to Paul, do you believe the Healthy California Commission is help us or will help us or harm our cause?
That's Rusty Hicks, actually.
Oh, Randy Hicks?
Randy Hicks.
Randy Hicks. Okay, because I was like, Rusty, if he's joining in, welcome. I'm glad that you're here to be with us. But Randy, for those of who don't know, Rusty Hicks is the chair of the California Democratic Party, who is more than welcome anytime to pop in on office hours if he wants to know more about AB 1400 as well. We love our elected officials and party leaders to come in and learn a little bit about this bill and kind of hang out with us. Well, my take on the Healthy California Commission is that I think the intent was there to help move this conversation along. I think that with it came, people on the commission who are not on the ground anymore. And when you spend a lot of time up in the clouds, you forget what it is like on the ground. And not saying that's all the commissioners they did put a wide array of experience on there. And I understand that you need people who have got decades long of experience in high titles, but I find that when you really want to know what's going on with the people, you have to check the pulse. And who's good at checking pulses? Nurses. So I'll just say that. So I think that, you know, they just need to get an accurate pulse of the people. And I know the commission will be coming to an end in a few short months. So we'll see what their outcome is. Like I said, I think the intent was good. I just hope that they are thinking and keeping their finger on the pulse of the people with their decisions.
And I'll just add to that that there's a range of opinions certainly out there on this answer to this question. But I think it's probably the case that one figure has put some stock into this commission, at least, whose opinion can't entirely be ignored, and that's the governor. And so it may still matter simply because that's the governor's way of approaching this issue. But I think that we'll find out. Let's see, there was another question that I wanted to circle back to that was from Matt.
Oh yeah, calling out a residency. Hi, Matt.
Hello, Matt. And so I take it to mean that you are residents and have somehow, because you've taken a little of your precious off time to join us, so welcome. And Matt asks a couple questions. So one is, does this bill have a funding mechanism well defined yet? And then two, where are we at in the state legislative cycle? So I will actually answer them, the second thing and then the first thing. And so in terms of the state legislative cycle, the bill was introduced in February. It was in April turned into a 2-year bill, such that it will next come up for consideration in the Assembly Health Committee in January. So for all those of us who support it, and that, I mean, certainly that's who we are, this represents time to build more support for it and build political pressure and movement for it. But it is also the case, and this now relates to your first question, that there are elements of it that are still kind of under active consideration by the relevant legislators. So in your first question, you asked, does this bill have a funding mechanism well defined yet? And the first thing I want to, before I kind of get into the nitty gritty of that, is just say something very important and simple, which is that single payer is a cheaper way to do healthcare than both what we currently do and almost all proposed reforms that aren't single payer. And so in that sense, we spend more right now than we need to on healthcare, and we could actually spend less and cover everybody and do a much better job of it, and single payer is the way to do that. So in that sense, the answer is the money is there. But I know that you are asking a more specific question. And so then let's just delve into that a little bit, because the question is actually, I assume, about what would all be all the funding sources for a single payer bill in an individual state. So if AB 1400, as currently as written, was passed into law, then the next thing that would happen is it would set up a board to sort of get the structures up and running, and it would also require then the state, presumably the governor, to apply to the federal government for these specific waivers of federal law to do the following thing. So let me back up and just say that a single payer is about having one pot of money that pays for everything. So what would be the sources of money for that pot? So one would be existing state taxes that fund healthcare. That would be number one. Number two would be existing federal appropriations that pay for healthcare in a state like California. Things like Medicare, or Medicaid, which is Medi-Cal in California, or Healthy Families, or some other programs, including the Affordable Care Act. Now, in order to spend that money in a way that is not how they're currently spent, which is through multiple payers and for only certain populations and leaving a bunch of people out and all that stuff, we would have to get waivers of federal law, and there's mechanisms for doing that. So that would be another big source. That would still then lead very likely to a need to raise some more tax revenue. And maybe that's the part you're asking about in your funding mechanism question. But before we get into that, it's right to say too that when you consider taxes, you also have to consider the fact that a bill like this as a law would end premiums, would also end all out-of-pocket healthcare costs and costs at the point of service, things like deductibles and co-payments and things like that. So when you look at what all that means to individuals, it's the net of those things, any taxes, and then, but also certain costs to businesses and others and individuals that have disappeared because they're no longer needed. So then I think that might maybe get to maybe what is the answer to your question is, that is not yet, but we have heard very actively from the legislators on the discussion about some of the possible tax programs, and they are very well aware of the issue, so that the taxes that would be needed for this would either come as amendments to this bill or as a second or as a separate bill. But it is very important to understand that this represents less money out of people's pockets, not more, in almost overwhelmingly in all cases. It would obviously depend on the exact nature of the taxes, the individual.
Exactly.
So that's what I wanted to say.
So I just wanted to add to that, because we actually had a conversation not too long ago, well, earlier this week, oh my gosh, my brain, well, last week, but when it comes to taxes, and I just read it in the basic principles, progressive taxation. Nobody wants more taxes. I totally get it. But when you think about what's going on right now, for employer-sponsored healthcare, for example, I work. So I pay my insurance, premium through my employer, which is a portion of what my employer pays. And so let's say I pay about $400, 400 some change a month for my PPO good, quote, big parentheses around good, insurance. And so then I still have to pay co-insurance, $25 to see a doctor, $30 to go to urgent care, $150 to see an ER physician, $300 if I'm not admitted. I still have to hit my deductibles. If I don't hit my deductibles, I'm paying a higher rate for medications and services. So I'm being pinched here, all over, little money taken out on top of that $400 and so I don't have the exact number, but I did this before with a previous job where I added up, I'm paying about 6 or 7% of health just in my healthcare fees, on top of still paying for Medicare and, all my payroll deductions. And so when it really comes out, when they are going to use the word taxes against us, I just want everyone to remember how much you're being pinched. And it's not all at the same time. That's the reason why you don't feel it until you have a major medical crisis, or someone in your family does, and you have to have a GoFundMe to offset those costs. But you're being pinched here. You get pinched here with your paycheck, and then you actually have to go to your physician. So you've been pinched here when you pay that copay, you get pinched there, and you get pinched and you get pinched. They may not all hurt at the same time, but that doesn't mean that they're not happening. And so what we're trying to do is take all those little pinches away and put it all under one, and then actually it be less than what is going on now. Because like I said, for most people who are just, average health, not having a major medical crisis, it might not seem so bad right now, but until you do, and statistically you may. So that's what I want to emphasize on the cost and the funding structure, because I know the opposition, people who oppose this, are going to drive heavy that word taxes. And I want everyone to know that that is not going to be the sore spot, because you already have your money being taken away. It's just subliminal, but it's still happening. And it still hurts when you think about it and you add it up, because I got a little shocked when I was adding mine up. But then I want to go back to Chris's question. It's been waiting in the chat for about 20 minutes. Chris asked from Facebook, is there anything you can think of that is helpful that the insurance companies provide? If so, who would take over those services? And when I was reading this goes back to some office hours when we were way young, baby office hours, but we discussed this about the utilization management and billing. Like Medicare doesn't do their own billing. They offset to or they outsource to someone else, I believe. Dr. Bill or Rondi, or do you guys remember that conversation? And so I think that what I could see the insurance industry, the workers being needed, is because that utilization management, knowing guidelines, because even with AB 1400, we'll be kind of using Medicare guidelines as at least a beginning structure. And people who know those are the ones that are going to be needed in CalCare. So I think that there will be some transition. I can't paint the picture vividly right now. It's kind of blurry, but I do know that there is going to be some transition there when it comes to that utilization part, but not like, it's not the utilization review that was bad. And I talked to this about with some coworkers, because I do clinical case management. Utilization review is part of what we do. It's not the review part, making sure that the care is necessary, making sure that, you're getting the care that you need or not getting what you don't need. But at the same time, what's the difficult part is having to sit there and say, well, oh, we got to call the insurance because it wasn't clear if they approved this code. Oh, we've got to call the insurance because it wasn't clear about this. And we're sitting with two phones in our ears because we're trying to call the insurance. If there was just one guideline there, or one thing to follow, guess what? I don't have to spend 45 minutes on the phone calling insurance. And trust me, I'm not a cheap date. So I think that's one thing. I'm sorry, Chris, if that was a very, very broad, vaguely painted picture, but that's just my thoughts on that.
Yeah, I'll kick in something, which is that, anybody who spends I think almost any time dealing with health insurance companies can mostly see that what's going on is somebody trying to make money. And it's not always presented that way, but you can often analyze it that way. And I think it's mostly correct. I guess one thing that insurance companies do is they send money to things like hospitals and providers. And those are just functions that in other countries are just done, for example, in Canada, is just done by the government. And there's no particular reason why it has to be done in the private sector. That's just sort of routing of funds to people. So I think that's my thought there. Anybody, let's see, questions?
Yeah, I see one from Jackie, that from Facebook. Did I skip over anybody? I'm sorry if I did.
And if you feel skipped over, put your hand up.
Yeah, if you're in a Zoom room, please feel free to put your hand up. I'm skimming the chat as much as I can. But Jackie on Facebook said, I wouldn't mind taxes if it goes for something good as healthcare programs such as CalCare. We just don't see the total amount of fees with health insurance, but it does add up. And you're absolutely correct. I would like an itemized tax receipt. If CalCare doesn't pass, I'm going to lobby. I'm going to write a bill for itemized tax receipts for my payroll taxes. I want to see where every flipping dollar of my taxes are going. If they're saying we can't afford CalCare, I'm saying that I'm calling BS on that because I want to see where my tax dollars are going. So that's just, that's not a threat. I'm not making any threats that I would write a bill about an itemized payroll taxes, but they have it in other countries. Other countries, they see where their dollars go. This goes to that goes to healthcare. This goes to the universal health or universal, college system that they have because they're so great over there. Anyway.
I see Paul Newman's hand up. Paul,
yes.
Do you have something you wanted to say or ask?
Yeah, recently I saw a commercial on TV about the ACA providing for a silver plan. They have a silver plan providing $0 premiums for people who are on unemployment. And I'm sure that's going to come up with this. How does AB 1400 compare to an ACA silver plan?
The fact that you have to have a silver plan.
Yeah.
I'm sorry. It's already apartheid. You know, oh, if the silver plan people get better than what the bronze plan people get better than, and if you're a gold member, you get better than the silver. That's not cool. So, and then also to add that in, who do you think that's gonna, that fee comes down to? When they do those cuts, they reroute that money to somewhere else. So they may take that little money that they're putting with the ACA and put that extra, whatever burden, financial burden that caused, they're gonna maybe add that into their employer pricing. So now the employers are paying more, which means the premiums on the employees go up. So like I said, it's the spaghetti. It's all that spaghetti. Because somebody's paying for it, and trust me, it will not be the plan.
Right. So, and what made Paul, I think there's, I have a thought about that question, which is that it's very evident to people like across the political spectrum, and, you know, like during the pandemic and before the pandemic, that our current healthcare system is really bad. And the pandemic has sort of like really shown more bad elements to it, right? And so people, whatever people's views of how to fix healthcare, they have looked at the current set of situations, and many have said, oh, something needs to be fixed. So for somebody who is sort of a proponent of keeping the ACA, in kind of keeping our current system, they're like, well, sort of like, okay, what band-aids might we come up with given current, like some of the current things? And so one of the issues would be that people couldn't afford plans on the ACA, and so there's one of the COVID bills steers some extra money there to lower premiums. And then the big distinction between like those gold plans and silver plans and all those plans, bronze plans that Gina was referring to, and that I guess that ad was referring to, is often how big the how big the cost sharing is. So if you pay less in a premium to get the cheaper plans, like the bronze ones, then you end up with bigger cost sharing, like bigger deductibles and bigger co-payments and things like that. And so it's a lot of just like shuffling of money around. It's sort of like you're like, well, I'll try to pay. It's like a gamble. Like I'll try to pay less now in the hope that I don't actually need healthcare later on, and that the deductible won't matter, and that kind of thing. So I think that awareness of deductible problems has also pushed the like ACA supporters out there to try to do some fixes there. But so then you could say, well, could we just fix all that and would it all be okay? And I think the answer is no. Like as in that those band-aids over the years, which the ACA is kind of itself like a large mega band-aid, have not really done the job. And they've not done it in a whole bunch of ways. And so some is by still preserving all these structures that essentially like siphon tremendous amounts of money out of our healthcare system. That lost money, like all the money that goes to insurance companies and their overhead and their profits and all these other things, that's a big part of where the money has gone that would otherwise have maybe contributed to, for example, things like higher wages for workers in general, but also just for covering everybody. And so, and then as part of that same set of structures is the maintenance of a separate program for the poor, for the poorest, which is Medicaid in California, or Medi-Cal in California, which is Medicaid. And, and that is a program that is separate and unequal for people. So I think what you are seeing, and there's been some news stories of efforts by the present administration in Washington to try to make some improvements to the ACA. But like, I think we've heard that story before, and it's not really the way to fix our healthcare system.
Nope. Trust me, I've been there. And if it was working, I would not be here. I would be providing the opposing conversation, but no, I'm telling you, it doesn't work. I've seen it on all sides now. I just want to point out what Carol had put in the chat. And Carol, I don't know if you want to come off mute to, provide your story, but it's very interesting. And someone who's worked on that side. I think it's actually interesting that they are, asking for a secondary, but I'll let you, if you want to talk about it. If not, I can share it. Oh, you're there. There you go.
Hi. Yeah. Like I said in the chat, this is a first. I have my own insurance through my work, and my husband's union will provide a secondary insurance to a spouse as long as they're not the primary. So I, went for preventive care. I had an annual physical, and I get these bills online saying claim denied because I didn't provide information about the secondary insurance. Now, I provided it at the doctor's office. They made copies of both cards, and that's always been enough in the past. But now they're saying, oh, you have to, put this secondary insurance information in on the web, the portal. And it was not easy to find. They asked far more questions than once I got to the form, they asked far more questions than they told me they needed initially. And so it was just another hoop, another waste of time, and another bit of confusion, in the hopes, the insurance company is hoping that I wouldn't see this. And so then I just end up paying for, paying out of pocket, for the whole thing. So, it's just another game. And, this is why the ACA, it still involves insurance companies. And this is why we need AB 1400, because we need a simplified situation, and we need single payer.
Well said. And I will say that story is, it's representative of the insurance menace. Like, yeah. Absolutely. Like and one of the, I wish they would come out and say things like, we're just denying this because we'd like to profit more, but they don't. They're sort of it's couched in these kind of, pseudo official kind of, I've had individual circumstances where I asked I prescribe a drug and it's not paid for. And then the company sends me a form that's their prior authorization form. And then I fill it out and send it in. And then they tell me it wasn't approved because I put it on the wrong form that they sent to me. Mm-hmm. It's your sense of that there's just another level of what this is actually about. And that is systematically to deny care as a strategy, as a bottom line strategy. It's part of the toxic menace of the insurance companies, no question.
And the thing is, I did preventive care, which in the long run will save the insurance company money. But the other thing is, this is a minor situation compared to somebody who has cancer or COVID. I'm healthy, I'm angry about this, but I can deal with it, and my husband will listen to me rant, and it will give me incentive to do all the volunteer work I do for AB 1400. So I just want to point out that when you're sick, and you have things like this pop up on your email, and you don't have the energy to go after them, then you could get bills that you end up paying for, even though you've paid your premiums all along. And because what they're saying is, if I don't rectify this within 45 days, then I have to go through another process. So, so that's all I need to say. But yeah, it's just another example of how these products that the insurance company are selling us are not, they're really undermining us.
Yeah. Thank you. I saw another thing in the chat that I wanted to amplify, which was also from Matt Musselman, who again is a resident. I don't know, is Matt still here with us? Maybe he is. But let me just read it. So Matt says this: I take care of undocumented farm workers who pick strawberries or lettuce for a living, and many of them have no health insurance and go for years without seeing a doctor. Some of them qualify for a local program that offers a limited insurance plan to folks who don't qualify for Medi-Cal, but they cannot get coverage for specialty referrals or certain meds, and it's definitely an apartheid system, is what I'm trying to say. So many poor outcomes that are preventable. And so I think what he's referring to is that, a pretty big part of our uninsured problem in California, and the problem of our health system is not only about people who are uninsured, because people who are insured, as illustrated by the story Carol was just sharing, have challenges, some very significant challenges. But for the undocumented, which make up maybe something like half of the uninsured, or have over the years in California, there's a particular set of problems. And so one is that for the most part, they've not been eligible, certainly for federal healthcare programs. In California, Medi-Cal, which by law recently has been expanded to provide some more coverage for some people who are undocumented, but that raises some other problems, which we can get into. But for the most part, our system has left behind tremendously a bunch of human beings who are our brothers and sisters and who live in our state, and in fact do all kinds of things, like you and I, like everybody does, which is to try to feed their families, and actually to try to feed everybody's families in the case of farm workers. And our system just fails them systematically. So, and there, sometimes like the counties, like LA County, for example, will try to put in a patch in LA County that's called My Health LA, to try to help folks in that place, but they often really are second or third class plans, or they're not really plans. Like sometimes they have stuff like this, like they'll pay for some clinic visits, they won't pay for specialty care, they have incredibly narrow formularies, and problems continue. So AB 1400 would end that, because AB 1400 would cover everybody who's in California, irrespective of their documentation status. So I'm looking down the question list.
Hey, Ron.
Yeah, go ahead. Yeah, some things are comments, not questions.
If I could just jump in and say that we all pay for the healthcare needs of everyone in the state. That's beyond dispute, right? So it doesn't matter. And I worked in the emergency room for 37 years of my career. And people walked in, and there are laws that say that you can't refuse to treat people. And even if you send somebody to another emergency room, that's called dumping unless you've made an arrangement for them to go to another emergency room. There's the EMTALA law, the EMTALA, which is, emergency medicine triage. Basically, you have to make sure that someone is stable to be moved, and that kind of thing. So who pays the bill when the patient can't pay the bill? And most of the time, hospitals, and Jedi Gina can jump in here too, most of the time hospitals are very expert at qualifying people for assistance, whether it's through the state or at the county level. And every county may call it something different. I live in Orange County, and we have a system called Cal Optima that qualifies people for medical assistance. But who pays that bill? We do. The public does. We all pay that bill. So it's incredibly stupid, just stupid, that we don't take care of people's health needs on the front end, and we let them get so bad that they end up in the ER on the back end. And I can't tell you how many times, basically it was every shift I ever did. And I worked night shifts for the most of my career in emergency medicine. And people come in at night, usually out of exasperation. I mean, sometimes it's out of convenience because they happen to be night people also, like I was. But most of the time it's out of exasperation. They just can't deal with the problem that they've had, ongoing, until it finally comes to such a dramatic head in the middle of the night, maybe on a weekend night even. They've been holding out, trying to find a resource. Maybe they're planning on going to Mexico for that toothache, whatever it is. They end up in the emergency room in the middle of the night for a toothache, for a damn toothache. They end up in the emergency room. How incredibly dumb is that? That's the way we're taking care of healthcare needs for people in our state. We, meaning you and I, we're all paying for that because somebody's going to pay for it. And that means that we got to get smart. And people in California have to get smart and pay for these things on the front end. And anybody who lives in California, I don't care who that is, it's like the insurance companies, business in general, they like that term, have skin in the game, right? So you were talking about cost shifting. So they want to shift the cost to the consumer. They call that having skin in the game, so you don't overutilize things. Well, the only skin in the game that you should need here is human skin. If you've got skin, then you've got skin in this game. And that's the way we need to provide healthcare for anybody who has human skin in the state of California, because it's incredibly foolish and costly to pay for it on the back end. And that's what all of those, I'm not sure who it was who asked that question. Might have been Michael's iPhone, at the start of this meeting, about the economic feasibility studies associated with this bill or any of the single payer bills that we've had in California. They all say the same thing. We stand to save about $1 billion for every million in the population. They all say that. In fact, they use that as a target. They say, okay, this is about how much we're going to save, because every study that's ever been done has shown we can provide all of these services and end up with about that much left over. And, and they do that and then adjust it on the front end, what all those costs are. And guess what? Doctors, hospitals, all healthcare providers and technical people, they all do well in that kind of system too. So, so it makes no sense, dollars and cents, economic sense, and it makes no sense from this kind of state of the state and the communities that we all live in to not do it this way. It defies reason and logic that we haven't done this already.
Exactly. But see, the thing is, it goes back to that conversation I said at the beginning about the commission. When you have people making the decisions who have not touched the ground in several years, maybe decades, it's really hard to know, to see that. And I'm not downing it. Like, I really would encourage an open conversation. Like, I'm trying to be the most diplomatic thing. I'm a Libra. It's what I do. But at the same time, I've noticed the difference. I've seen the entire spectrum of healthcare, from not having insurance, experiencing that myself, from being under Medicaid as a child and into young adult, to having full premium PPO insurance. The entire spectrum of how you're treated, what the people do, the communities. And so you're absolutely right. And I've spent 5 years working night shift at a level 1 trauma center too. And so the toothaches are real, but trust me, those people are not coming to the ER with a toothache because they just didn't want to go to the dentist. They just don't have dental insurance. And they get so angry when we tell them, no, we can't extract that tooth. Dr. Bill was not trained in tooth extraction. I'm sorry. He will see you. He may provide you some pain medication and antibiotics and tell you that you have to go see a dentist. But guess what? You don't have dental insurance. So how the hell are you going to go see a dentist? Well, guess what? Okay, maybe what you can do is go to a dental school. A lot of people do this. They go to the dental school and let the dental students practice on them. That's how terrible it is right now. So instead, if you don't have dental insurance, you try to go to a dental school, which still has costs associated to it, to have that tooth extracted. But those wait lists are so long because you're one of many, many, many people who do not have dental insurance. And I'm talking about, these are employed people, by the way. These are people who have jobs. So for my conservative friends out there, it's not because they're not working or that they're milking the system. They have full-time jobs that still don't have dental benefits. And so they went to the ER. Dr. Bill was like, I can't do dental extractions. I might have a friend though that did what I met when he was going through, but they don't do dental extractions. And I mean, truthfully, you don't want Dr. Bill doing a dental extraction. He may come to you with some pliers or a hemostat, and that would be hilarious. But I wouldn't want Dr. Bill to do a tooth extraction. He can intubate though. But still, I would still, like, that is such an extra cost. So now you've added the ER cost. Now you may have to, you've got to pay your prescription, get a prescription filled, which you may or may not be able to do for that antibiotic and pain medication. And then now you've got to go to a dental school. And so now, like I said, the cost keeps layering up. Here comes those little pinches, pinch, when all we could have had was CalCare. You shown up, maybe you needed emergency dental. Maybe you needed emergency dental, and you would have taken your CalCare card to a dental office, hopefully before it got to that point where you needed that extraction, and got your dental work taken care of. Maybe it just needed a filling at that point. And so we would have prevented so much additional cost if you just would have had the coverage. And so that also goes to a responsibility on the people. I'm a mutual responsibility. I'm an equal opportunity responsibility person. So as the people, once we get CalCare, it is our responsibility to take care of ourselves when we need the care. When we start feeling that tooth hurts, we might need to go to the dentist, because now we will have no excuse. If we have CalCare, I'm going to look at you all types of crazy and be like, well, why didn't you just go get taken care of? Oh, well, I didn't feel like it. Well, guess what? I don't feel like giving you any pain meds either. So there's that. But no, I wouldn't do that. But I'm just saying that is the point, is that when we have CalCare, then we start talking, we can really drive preventative medicine. It's hard to provide or to drive a preventative medicine conversation, especially right now in the world where not everyone's insured. So it's not fair to me to talk in my high horse about preventative medicine to people who may not have the insurance or the cost to be able to cover the cost of that preventative medicine, going to that doctor, seeing that dentist, paying those copays, getting those regular medications. But when you do get CalCare, then I'm going to drive hard preventative medicine, because I need CalCare to sustain. And for it to sustain, I need America, Californians, I need us to want to be healthy. And so that means we're going to go to the doctor on a regular basis. We're going to see Our primary doctors, more like once a year at least go get a damn checkup once a year. Our dentists for our yearly exams, our eyes, our mental health, we're going to have all that covered so you can do that on a regular basis because you're going to be healthier, you're going to be happier, and then you go do whatever you want to do with your life. All right, going to questions. I see a couple of hands up here. I want to go to Michael. Nice to see your face, Michael.
Hi, sorry. I was eating, so I didn't.
Oh, no, you're good.
Maybe stuffing my face. I disagree with you about preventive care. I think that if the pandemic has taught us anything, it's that public health is all about preventive care. And so I would start there. The second thing that I would look at least in terms of this bill or any kind of legislation, is it all falls on its face when all it talks about is how are we going to pay for, the providers. It's true we have to have trained doctors and nurses and respiratory therapists and surgeons and other specialists and so on, but we also depend heavily. I think I would argue that the janitor does more for the public health and safety of the average person in a hospital, and that includes the visitors as well as the patients, than a physician does. And yet they're the worst paid. The more valuable your job, the more you get from out of it, the less pay you're expected to receive. And we do that to teachers, we do it to caregivers, and we need to do what economist David Graeber has called creating a gross domestic product, not for productivity, but for not a gross domestic product, but a gross domestic care. And so that the caring professions are paid for. And so when we have elderly people in their homes, and that's really where they should be, not in congregate facilities. When they get care, they should have enough funds for them to eat and for the people who care for them to eat and to have housing and to be safe otherwise. And
Michael,
all this leads into the need for public health. We don't have a public health system.
Yeah, Michael, let me respond.
And I would go one step further and say that a physician, Michael Fine, has written a book about healthcare reform and talks about community-centered care, and out of the state of Rhode Island where he lives. And we don't have anything like that. Instead we create more problems with the systems that we have anyway. And I'm not saying that I wouldn't go to a hospital. Michael,
let me just because you brought up a bunch of really interesting issues there, and so many so that I don't think we can answer. Like I wanted to stop you for a second so we can kind of answer a few of the things that you mentioned, because and one of the things about office hours is that it's about educating people about what's in this particular bill. And you are right that this bill, I don't know if you spend any time reading it, I recommend you do, but it does not purport to solve every known problem, even within the healthcare system. But I want to bring up a few of the things that you brought up with relationship to the bill. So you talked about, and just present what the bill does or doesn't say about them accurately. So the bill doesn't define what a janitor would make or a physician would make. So you're correct if that it doesn't sort of set wages in that way. But I want to give you a sense of like how those things would be determined, generally speaking. So janitors primarily work in institutions and buildings, and the bill would primarily pay institutions through something called global budgets. Global budgets. Those are have been common features of single payer programs more recently. And a global budget for an institution, that represents a big change from our like the current way we do things, which is that things like hospitals get like fees for services, and then decide to pay people within the hospital who work at the hospital whatever they want to. So the bill would steer us toward, not steer us, it would
So we
define,
should continue to pay doctors more money than janitors.
No,
despite the fact that janitors aren't killing people, but doctors are.
Well, I want to clarify that.
I just want to say it doesn't really address that question, but it does address how institutions and individual providers would be paid. So if your point is that the bill doesn't appear to change the relative incomes of doctors and doctors and janitors, I think you're right. I think that's a reasonable. I think that's a reasonable point.
You missed my point. You missed my point. You missed my point.
Oh,
this went right over your head. Look, I'm just telling you, I have a lot of experience with going back 6 to 8, 10, 20 years, trying to get Sacramento, where I live, the people in Sacramento to pass a bill to do something like this. And I can tell you, they don't have any interest in it. You know, they don't care. They don't care. They're not interested. And even if they were, you could just give them the money and have them allocate $1 trillion a year to all the insurance companies so that they get their benefits and just leave us alone and get the hell out of healthcare. But that's not the case. And my complaint is that this bill, like any other bill, really only looked at the system instead of looking at what it is that we as human beings really need. And that is a public health system. And we don't have that. And that was the argument that Michael Fine made in his book on Healthcare Revolt.
Well,
that we need community-based healthcare.
So I wanted to address that. So with AB 1400, this current bill, this bill is really a building block bill, right? It's an exploration bill. The problem is the reason why we can't build a public health system is because exactly what you said. We can't get past that legislative hump. But if we can get this bill past the hump, then we can continue to build upon that. That's where I was going with preventative medicine. Unfortunately, we can't just hit it hard and say, let's build a community public health system, because we know, well, if it were that easy, it would have been done by now. But we have to subliminally build it by putting kind of pieces in there. This is like the framework of that house. You know what I'm saying? AB 1400 is a frame. It is not a fully built house. It is a frame of the house. And then as we get that passed, as we start building AB 1400, we start building those extra layers in it. But we have to get this specific legislation passed so that we can start building it. Actually written in AB 1400, I can't do shit until the board and gets it all cleared and passed. So truthfully, the bill's exploration more than anything. But right now, this would set precedents, not only for California, but for the United States with the National Medicare for All. So passing this bill is, like I said, just building the frame. It's the architectural framework of this system. But yes, public health and community-based health is huge. It's just that right now, I need to get this foundation laid. And that's what this bill is really about, is laying that foundation so I can build all this on top of it. But I can't get everything through this legislation. It's just, the more I give them to pick apart, the more I will. So now I'm really trying to lay a frame. And then from there, build and build and build, because now I have a ball that's rolling. But right now, as far as I know, and I'm a millennial, I know I'm young, I have not seen this ball get rolling anywhere in the United States. And this right now could get that ball rolling. And once it's rolling, they know they can't stop it. And I think that's the reason why there will be so much opposition, because they know when they let this ball rolling, it's going to be like, Raiders of the Lost Ark. That's the right one, right? Where the big ball, he pulls it and it starts running. Okay, yeah, right, millennial. Okay, anyway, I'm sorry. Dr. Bill, you had your hand up too. I just want to...
I think Michael has a really good point about the pandemic and public health and meeting public needs. And I want to chime in, actually add on to what Gina is saying, that this bill provides that framework because we're talking about public agencies, a public board, prioritizing and allocating the money that comes from us, the public, for public needs. So we are talking about establishing public, whatever it is. So it could be community clinics, it could be allocation to already established hospitals and clinics, or building new ones that are needed in the state, especially in those underserved communities, whether it's in rural areas or inner city areas. So, and that is the lesson of the pandemic. I think you're absolutely right. And it is about preventive care, because people don't have a medical home under commercial healthcare in America, and definitely in California. And, we don't have a medical home like they do in the other advanced countries in the world. And that means that we're subject to all the medical misinformation that we get from TV and the internet. And that's why we have rampant vaccine refusal at this point. We still have so many pockets of people who haven't been vaccinated, and this pandemic is going on much longer now and worse than it should, is because we don't have those public health services that you're talking about. So, so frankly, I think we'll just have to agree on this thing. Thanks.
Okay, that's a good dialogue. I love it. But yeah, I think that unfortunately, this health system should have been so far ahead. This health system, we should have been having, actually, no, I can't say we, but this conversation actually was being had in the 90s when I was still a wee tot. But, thanks to Maureen for giving me the history of the single payer. But, I think that the strategy that our legislators at all levels want to take is one that they should have initiated circa 1990 for it to be fully where they think it would be now. That's just my thing. If this incremental stair-step healthcare system that they're trying to build should have been started, they should have started building that staircase, I want to say back in maybe circa 1990, when I was just maybe about 3 years old. And then this angry little millennial probably wouldn't be here right now, and I'd probably be eating avocado toast. But here I am as an angry little millennial, because now they're trying to stair-step it during a major global pandemic. All right, do we have any more questions? Ron, do you see anything in the chat?
Let's see, I am looking. I mean, I think Maureen Cruz, tireless activist and leader in healthcare for all Los Angeles, had mentioned something at 5:53 p.m. In the chat that I thought was worth picking up on. And this is what Maureen said. Kaiser is being sued for upcoding, exaggerating health needs in Medicare patients. Also being sued by San Diego County for falsifying provider and service network. 35% of providers listed are not in fact available, not currently with Kaiser. Same for Centene and Molina networks, 85% correct. All three being sued by San Diego County. So she is identifying a few problems in our current system that I think would mostly be fixed by a bill like AB 1400. So one of them is institutions like Kaiser would no longer bill fee-for-service. That would be limited to independent providers, like individual healthcare providers would do that. But as I was kind of mentioning to Michael, big institutions would be, and by the way, those folks still could potentially do kind of like upcoding shenanigans, but I'll get back to that in a second. But big institutions would switch to global budgets that I think would eliminate the kind of things that she was describing there. So another, and then another thing that would be that she's referring to there is a problem in our current system, which is what are called narrow networks. So because we have like 1 million different payers in our healthcare system, and they then have like all these different little networks of either hospitals or healthcare providers or both, that they will let their people who are members of their insurance go to. And those networks, in some cases, are falsely presented as bigger than they are. And that has been a repeated problem. And then the other thing then is by limiting them, that ends up being a method to limit utilization that helps make health insurance companies more profit by essentially making it so there's nobody for you to go see for the problem that you have, or it's somebody who is far away or has a very long waiting list, or it's a long time to get to see that person. So maybe your problem will go away, or maybe it won't, maybe you'll suffer more, or maybe you'll just go somewhere and pay money out of your pocket so the plan won't have to pay. So all of those things narrow networks, because the way the AB 1400 is written, it would essentially make almost everybody in network and not define networks other than just people are just part of the CalCare system. It would essentially end that problem too. So I thought that was kind of a comment on our current system that sort of raises the question, well, how would AB 1400 fix those things? And that's how. One thing Michael, who had just spoken, also mentioned in a comment was now they're billing me demanding payment despite presenting insurance info at the local clinic. And so one thing he's bringing up there is the problem of the need to pay money for stuff at the point of care in healthcare. And that's something that AB 1400 would eliminate. It would essentially end payments at the point of care. And that I think would represent a big step forward. And that's clearly laid out in the bill. So there's a couple of things that were in the chat. Gina, do you see any?
Yeah, and I just want to say that payment at a point of service is what really delays a lot of people in seeking care when they need it. And when that taken away, I'm hoping to see more people seeking care when they need it, instead of waiting until it's exacerbated where they're going to see Dr. Bill for a tooth extraction. I'm going to pick on you, Dr. Bill. I kind of now need to see this. I need to see Dr. Bill pull a tooth. So I think that that is a key factor that I hope to see with CalCare, is that, people start getting the care, but it goes back. We're going to have to do some education too. But I do see something from Randy Hicks from Facebook. He said, we need to list all the scandals of managed care. And I'm like, so it won't be a list, it will be a scroll, like one of those long scrolls you just unravel and it just goes for long and long, it just goes down the hallway. It would be one of those. But I think I remember on a previous office hours, it was brought up about doing something like Courage Campaign, but I don't think it was for like health insurance companies. I think it was more for the legislators still about where they stand on healthcare. But it would be cool to have a report card kind of for the health insurance, health insurances too, like Kaiser, Anthem, and stuff like that. Where do you sit on these issues? But no, the list would be a scroll. And it would just imagine that cartoon where it just keeps rolling down for all the way down the long hallway and goes down the steps. That's how many of these scandals would be written there. And I can't even go into it. But right now, the thing is, I think one of the biggest things is rerouting care and for profit, which is not illegal. It's just not, it's not a good ethical practice to basically, contract with providers for lower rates, even though that they do not provide the best care, but they provide a lower rate, and that's what matters. But their care outcomes are barely passing. And that is one of the things I see a lot in managed care, is that type of practice, because it kind of goes into that capitation world, which people feel one way or another. Capitation, fee for service, conversation for maybe another time. But, it is one of those things where I do see that's where the managed care world, they can get their bread and butter. And that's just coming from having experienced it, haven't seen it. But, neither here or there. That's something we'll go into. Do you see something else?
Right. No. Well, Erica Ferriston, who is on our call or on the Zoom.
Hi, Erica.
Hi.
Did you want to
Yeah, can I
say something? Yeah, go ahead.
Okay. So first of all, I'm sorry I'm late, even though I know there's no late. I know
There's
Dr.
no light.
Ron would say there's no late in office hours. School starts tomorrow. So I've been really busy.
My heart's with the babies.
Okay, so I got this message in Facebook from somebody, you know, we were going back and forth about CalCare. And I have an idea how I would answer this question, but I would really like to hear how you guys would answer this question. So I'm just going to read it the way it was sent in. She writes, I've been at Kaiser since birth, although I've had secondary private insurance before. People like me are going to get fucked with a mass influx of people into that system. Who is your health insurer? So her objection is to CalCare because I guess more people would get healthcare at Kaiser, and she's feeling like that would be bad for her.
Not necessarily true. And I get it. So she's kind of like a some people in, some people out type scenario. And that's the same thing we've addressed before when it said, well, what's going to stop everyone from flooding straight to UCLA or Cedars or some of the top tier or advertised top tier hospitals? And to be honest, nothing's going to stop them. But let me ask this. What do you want to sit on the 405 coming from, let's say, South LA, Long Beach, Carson, to get to UCLA just because it's a fancy hospital and you can get there? No. Would you want to sit, you know, and then also on top of that, Kaiser don't, like in certain instances, and especially some in the Black community, there's another word for Kaiser, they call it killer Kaiser. So Kaiser ain't the highest sought after place, baby. So, you know, I just want to put that out there. So I really diplomatically would say to those people is that when people seek these higher end hospitals because their hospitals have been driven into the dirt, and they, you know, why I can go to my clinic that looks like a fucking Apple store, excuse my language, but it does. It looks like a legit Apple store. But if I go to the Hubert Humphreys clinic on Slauson, it looks like a, you know, a third world country over there. So the disparity in resources is what the problem is. With AB 1400, we're going to start to address that disparity. Truthfully, clinics really don't need to look like an Apple store. That's an aesthetic thing. But as long as they're clean, as long as they're providing the care that you need in a fashion that you need it, if it looks like an Apple store, great. But if it looks like a regular office, okay, I'm not there for aesthetics, even though that has become a driving force of healthcare now, which we can discuss that later, HCAHPS and all these regulatory bodies and patient satisfaction surveys. But for your friend, I would just say, you know what, if the communities have their clinics and their hospitals with the funding they need, which this bill will provide, you're probably not going to have to worry about that person driving up to Kaiser West LA. There's a few more Kaisers they'll have to pass. Anyway, Kaiser's big throughout LA. There's plenty of Kaiser locations. I understand she's talking about the managed care system. The managed care system cannot handle an influx of patients. It just cannot, because the utilization management part is weak. If the utilization management part was a little better, maybe, but it's weak, and they're going to clogs the system, and that's where it becomes an issue. But I don't expect that to happen. I expect to see that the clinics in those areas start to look a little nicer and people get a little bit more comfortable, because nobody's going to sit on the 405 trying to get to UCLA when they're sick.
So I see another question. Ron,
can I just?
Oh, sure. No, go ahead. Yeah. Go ahead.
Well, first of all, thank you so much, Gina, for your response, and that's really helpful. And another thing that I see in her question, which I don't know if you want to discuss more, but you know, it's almost like I see what's not being said in this question is a mentality of there's not enough to go around, and so I've got to claw and protect what I have and can't let anybody else in. And I find that is a mentality thing that it may come in different questions or forms or statements. But I think that's an underlying mentality that I've been seeing with some people that, you know, object to CalCare. And so, you know, I would love to just hear, you know, a little bit, you know, CalCare really, you know, is the opposite of that mentality, right? And it's not what our, you know, dog eat dog capitalist system gears us toward. But you start to see with CalCare, not only is there enough to go around, it's actually better for you and for me when everyone does have health care. And we've talked about this before, that you know, it leads into other areas. It starts to ameliorate suffering and allow, you know, some support with our unhoused community to have housing and so on and so forth. But anyway, just wanted to throw it back out to y'all, more talking about the mentality of not enough and how CalCare is the opposite of that.
Yeah, no, you're absolutely right. I just want to say you're absolutely right. That mentality is driven into the psyche of all Americans, but that is a capitalist kind of like very, very aggressive stock strategy of scarcity equals profit. So if you make a resource scarce, it becomes more valuable. Unfortunately, people think that good healthcare is scarce, and that is a terrible, terrible mentality that we have, but it is not. There are a lot of good doctors and providers. You're on the call with quite a few of them right now, who provide good care regardless of what the payer source is. Most of the time, if our payer source was CalCare, you would still get provided that great care, probably better care, because, you know, Ron wouldn't have to sit there and fight Medi-Cal. You know, for his low income patients who still need to have their derm services. He'd probably be all happy and chipper, like walking in, be like, okay, you're going to get this treatment. I'd be happy because I'd be like, you know what? I don't have to fight the insurance companies to get this approved. What else do you need? Okay, yeah, we got this. Do you need that? Okay, yeah. We're going to help get you the services you need to get you the care that you need. And I'm going to moonwalk on out that room. But unfortunately, the mentality of scarcity equals profit. But anybody, Ron, you were going to add to that?
No. Actually, I'm pointing to Dr. Bill, but that's just because he's in the little square next to me, but nobody else can see that. Dr. Bill.
Well, yeah, I just want to add to that, because I think Erica is exactly right. Erica and you, Gina, are exactly right. And it actually comes in your CalCare principles under freedom, because capitalism is, you know, in this case, you know, maybe I'm showing my socialist stripes here, but when it comes to human needs, it needs to be socialized, because capitalism is a false promise of freedom in a marketplace. What is a free market? And we don't have a free market because we have a monopoly capitalism. And that makes it what they call a zero-sum equation. That means some people get all and other people get nothing. And, you know, so that creates this inequity. When you eliminate things like networks and other, you know, false financial products as barriers to access, you have so much more freedom. Then your freedom of choice becomes what is the reputation of that provider or provider group in the community. So you might have Killer Kaiser in one community, you might have Kaiser as king in another community, and it evens out. And you can look at, you know, other parts of the world where they did this, like Taiwan or Canada, you know, in the 60s and 70s. It has evened out, and you know, there's no need for these provider groups to disappear. You know, they don't just go away. They just change their business model so that they're paid like they get paid through, you know, Medicare now, instead of the false promise of monopoly capitalism. And we're not all making bad consumer choices based on TV ads and that kind of thing. We're making those choices based on, you know, word of mouth, like really what is supposed to be, you know, among communities, like, you know, hey, I need to see a doctor. Who do you know who's good, right? So you'd ask your family, your friends, your coworkers, other people in the community. You would get that kind of word of mouth, and you would go see them. They're not right oftentimes, and you'll have to go see somebody else, right? It's like asking someone who their favorite restaurant is, and you go there and it sucks. But you know, but you should be able to walk out of there and go somewhere else, you know, and you would be able to under CalCare. There's no impediment at all because at the point of service, it's free. So Gina's absolutely right. You're not going to drive too far. You're not going to fight too much traffic. You're not going to, you know, you're not going to drive all the way to the Puget Sound, you know, clinic in Washington State, you know, to go for your checkup. You know, you're not going to do that. So instead, you're gonna go local based on local recommendations and have no impediment whatsoever when you say, hey, that one sucked, I'm gonna try a different one. That's the freedom principle in you know, in that list that we do every week, and that's how it works out, you know. So kind of a long answer to your friend's point, but I think that we can feel better, at least knowing that, and then trying to convince others of that.
Thanks, Dr. Bill. I appreciate that response too. And it's definitely an interesting thing. It's going to be an interesting mentality. We're seeing this amongst people. This is kind of one of the points where I say I've lost faith in humanity, because I see the lack of compassion. The lack of being able, and that's what it really kind of delves down to, the lack of being able to put that empathetic, can I put myself in someone else's shoes that needs insurance? Can I put myself there? And I notice a lot of that with people. I'm seeing it a lot with the COVID, you know, people can't see past myself. But like I said, either way, you know, I think that we will not see an overwhelming with just people flooding one particular place in LA County or in California to get their care. Will these places probably see an uptick in patients? Yes. That might not be a necessarily bad thing. That might help their global budget in the next cycle. But at the same time, I think that we do have to ask ourselves too. It's like, well, what is our issue with someone else having the same things that we have? I see a question in the chat from Michael. Why are the healthcare labor unions, along with the firefighters and police, opposing mandatory COVID vaccinations? Ooh, that's a good one. It's not due to AB1400, I can tell you that much.
Well, although I actually think that in a way, Dr. Bill gave a pretty sophisticated answer to this question earlier, which is that, so the first thing is that their opposition is primarily based on misinformation, and or to the extent that there's opposition, right? But that part of healthcare and public health type misinformation is the absence of sort of stable, predictable places where people can go to get healthcare and get good information. And that is a problem at the kind of like the local, kind of like, is there a doctor I can go to, or a healthcare provider I can go to who can just like really answer my questions and clarify things for me? And also that, is there a public health system that is like, that has also built trust for people? And maybe that hadn't, because it had been starved of resources. And you know, in the countries where like there's more universal healthcare, there's more like the cost of sick care and those kinds of things are generally lower, and it sort of creates opportunities for other types of social spending, including things like public health, housing, education, nutrition. Something we spend less on, relatively speaking, in the United States. So there's some indirect benefits to doing a bill like this in California that actually I do think would go right to the heart of Michael's question. my thoughts there. But I think that's dovetailing on Dr. Bill. So let's see. Let's see. I'm not seeing any fresh questions in the chat on, are they? And is there anything outstanding in the in Facebook right now, or no? Yeah.
I will
No?
say this,
ahead.
if we can get AB 1400 passed, I'm going to get on my COVID soapbox, then we could possibly have our healthy Californians so that when the next pandemic comes around, we may be a little bit healthier and have better access to care the next time. But we got to pass it right now because the next pandemic is right around the corner. Unfortunately, it's just the way things go. All right, Paul, I see you have your hand up, then Erica.
Yeah, I had a quick question, and Michael's had one response, and but my question is as you know, many doctors have a concierge system. Under AB 1400, would that stop that, or they can still have it? And Michael, I know, says no, but I don't. He may know, or I was wondering what your thoughts are too.
So yeah, I've spent a long time looking at those that part of the bill because it's kind of interesting, and this bill and also the HR 1976 federal single payer bill on the House side have kind of addressed that issue in a new, slightly different way than previous single payer bills, I would say. So one of the things is technically, a doctor has to sign a contract, not technically, in the bill, that providers have to sign contracts with with CalCare to be part of the CalCare network. So they could choose to not do that and provide care outside the system. And that would look like, I think, concierge care. But there's some, like what you were saying. But I think that it would, of necessity, be quite limited by structures in the bill. And so one of them is that if a healthcare provider in California under the bill was starting to contract with individuals separate from this system and for covered services, then they would have to file an affidavit with the state saying that they were doing that, and for 2 years would be blocked out from the system, so that they would first have to make a choice, either be all in or all out. And most people aren't rich enough to sustain many doctors who are all out. There's just not enough rich people for that purpose. So I think that there would be this bill, I think, would lead to a little bit of concierge type stuff. But I also think this bill has the architecture to dramatically limit that. And I don't think you can have a concierge hospital successfully. That I think is almost impossible. Like even the wealthiest folks, or very, maybe a tiny sliver of the ultra wealthy, like pay cash for hospital care. Like this doesn't happen very often.
And you have to remember, the wealthy are wealthy for a reason. And it's not because they sit there and spend all their money. They invest it, but they do not spend it. They're not, if they have insurance or the ability of something else to pay for what they want, they're going to let that something else pay for what they want and keep their cash in their pocket. That's just how they got wealthy, for the most part. But also when it comes to concierge, you know, the good thing about AB 1400 is that yes, they can have practices that provide services that are not covered under AB 1400. Very few, like I said, going back to my Brazilian butt lifts, plastics, cosmetics, Botox, you know, injections, things, a lot of I think the concierge world can sustain with cosmetic, but not enough to where they will be able, it will be the same as it is now. You have your concierge cosmetics that aren't covered under insurance anyway. I think that world may still carry on because it wasn't something that was paid for by insurance most of the time anyway, unless it was medically necessary. So I think in that instance, all those injections and fillers and all those kind of more cosmetic beauty procedures that aren't covered by insurance will continue to exist the same way they have been. But can a provider create a concierge world that provides the same benefits that CalCare does? No. What I can see, just if I'm going to go out there just out of a rebellion sense, I could see that some providers may try to jump to that world because they're uncertain of how things are going to work out in the first rollout of CalCare, where they're going to try to create this and they may be X'd out for about 2 years when they do. And then after that 2 years, they're going to be hungry and they'll be the first ones putting their application in to be a CalCare provider because they're going to see that 2 years of being starved out of the system that they can't sustain, like, you know, Ron was just saying. I can see that happening. I can see a little rebellion there since we're kind of in our Star Wars thing. I can see a little rebellion happening where providers may get together and try to create a concierge group because that, I mean, sometimes providers do that now. They create their own IPAs and stuff like that. But I don't see that, like Ron said, it's sustaining. And I think that they would come back in after the 2 years where they would be able to reapply.
Yeah, I think a good analogy would be like, just because there's a few people, there's going to be a few people out. So if you're thinking about like public goods, like roads or whatever, like most people use the roads are there for people. Sure, there's like a few people out there who own their own helicopter and they helicopter to stuff, and that's I'm not going to lose too much sleep about those people if everybody has roads to get where they need to get to.
All right, Erica.
Yeah, I just wanted to point out, okay, concierge exists right now.
Yes.
You got concierge pediatricians, you got concierge, I mean, all the, you know, beauty stuff that you're talking about, Gina, is concierge anyway, because insurance doesn't cover it. You might go to a dermatologist where your insurance covers, but even if that dermatologist gives you Botox, the Botox is not covered. So concierge already exists. There's plenty of it. Those doctors, I would assume, would just remain concierge as they are now. But with CalCare, the whole point is like we would have, I mean, everybody would have healthcare. So the wealthy can continue to go to concierge. Maybe it's one doctor of concierge that they go to, but then, you know, they go to CalCare for everything else. So there's already concierge. There can be concierge doctors. That's their choice, their freedom. But CalCare, you know, allows for the masses to receive the same high standard of comprehensive quality care. So just wanted to make that point.
That's right.
Thank you. Looks like we have a question from Randy. See, Paul, you got me ready to call him Rusty. From Randy. Can we get single payer and master plan on aging? Because they are saying that managed care is the answer.
It's like a long-term care kind of question. So it's very relevant to the bill. So, I mean, because it's.
Oh, I mean, I thought you did. You want to answer? I feel like I've been talking the time.
Sure. Yeah, I saw you kind of thinking, so I wasn't sure if you did. You want? I did not mean to.
No, I mean, you know,
Go ahead.
Yeah, with regarding to AB 1400 and just on seniors and long-term care, this is very much better than what the current system is, for sure. And so, you know, I think that this will benefit our seniors a lot by providing them that additional coverage with the vision, dental, hearing, and long-term care. But, you know, I think that yeah, I'm still kind of like still trying to figure out the question about single payer and like adding single payer in this particular part, the master plan on aging, or is it like I'm confused a little bit on that one?
Well, so the master plan on aging was like an effort to look at, you know, it's like another commission kind of situation, I think, where because we have a big problem with how we take care of seniors, and it is very definitely related to our healthcare system, where there's a big emphasis on that unless you have a ton of money, that the way people who need long-term care, the way they end up getting that long-term care is through Medi-Cal, and that also requires things like spending down one's assets, and tends to emphasize highly institutionalized long-term care. So one of the things that AB 1400 does is it has like a comprehensive long-term care benefit that's built into it. And that would, and an intention, a lot of language, a pretty substantial swaths of bill aimed at not emphasizing institutionalized care, but emphasizing care at home or care in the community or other kind of other models. So we have the current system really doesn't emphasize that, but I can imagine that maybe what was in the question from Randy out there, and Randy, thank you for the question, Randy, not Rusty, that it is that the folks who are looking at the plan on aging, because they're maybe not thinking of this in terms of single payer, sort of like comprehensive whole lifetime care, that they're just sort of focused on the current institutional way we do a lot of long-term care in California. And there's a whole set of folks out there in California who are like, if maybe more managed care will help whatever situation it is. It's like there's a whole lot of folks where that's sort of the like wherever they see a nail, that's their hammer to that problem. So I may be speculating on what's going on there, but that's my speculation. And AB 1400 does have an answer, and it isn't primarily to sort of HMOize long-term care. So do you see any more questions? Hovering. Let's see. Yeah, well, I mean, if there's no absolute rule that says we have to go to exactly 7 p.m. Like we could stop at 6:51.
Yeah, if there's no more questions,
yeah.
We can gift everyone back 9 minutes, including myself. I'm studying for a board exam right now, so I would appreciate it. This is the other thing about the healthcare system, board exams. Why do I have to pay all these hundreds of dollars to take the exam to tell me that I'm good enough to be certified? Ron's good enough to be certified. You should have to pay hundreds of dollars to be told that, to be stressed out to take a test, to be told that you're good at what you do. But we must do it. It is part of what we do. So I have to take a board exam. This is more voluntary than what yours are, I'm sure. Mine is just more alphabet soup behind my name.
Well, I mean, it's sort of, you know what, that's an interesting question because it's related to how do you make sure, I mean, the purpose of like board certifications for stuff, there's a few, and it's different than licensure. Like board certification is not the same as licensure. So it's not something that creates like an absolute sort of moat of kind of around like a set of like a type of practice. So board certification is our strategy, one type of quality strategy, I guess. And the idea is, especially recertification, but certification and recertification is to demonstrate that you have a set of knowledge and skills, and that maybe that if they need to be recertified, that they don't erode over time. And I think that those are features of healthcare systems all over the world. But you could take the question and say, well, how would, and AB 1400 doesn't presume to change that whole set of things. It doesn't, it sort of identifies that the medical board, for example, I mean, that's more like licensure. The medical board and the nursing board still handle like licensure, but it does have some ways that it looks at quality, and it has some ways that it says we're not going to look at quality, and that is that we are not going to do paying for quality as a strategy. That's something that's not the case. So now I see a bunch of hands up. That's okay. So maybe we end up using some. So Dr. Bill, do you want to say something in relation to what I just threw out there?
Well, no, not in relation. Mine was real quick, just kind of an ending note, because we're ending the office hours. But it's my COVID reality check for California for the day, and which is 621,061 COVID deaths in the U.S., 621,000 deaths, 64,630 in California. And that's according to the Harvard Daily Tracker, which I dropped the link for in the chat. Of course, the Lancet Commission study that was reported out in February this year says a full 40% of those 64,000 deaths would have been spared if we had a single payer Medicare for all system. That amounts to 25,852 lives that could have been saved. So there's your COVID reality check for this week. Thank you.
Thanks, Dr. Bill. And then Michael, you had your hand up too?
Yes, my concern is about what you said, Jenna. Is your name Jenna or Gina?
Gina.
Gina, sorry. I called you Jedi. I was like, okay, sorry, Gina.
Oh, it's the theme.
You're a Jedi too, right? Okay. I reject the notion that the proposition that healthcare is a commodity. I also reject the notion that education is a commodity, and that's exactly what recertification is all about, or certification for a new cert like you're doing. I'm doing my recertification for respiratory care, and it's another $200, and all the CMEs and everything else, and it's like, I mean, I don't mind doing CMEs. I don't mind belonging to the doing peer review of studies and so on. But at the same time, it costs me you pay to play, and it should be the other way around so that people can eat. I'm retired, so I get a retirement, so I can do anything I want. And so I look at this as being, really a curse and a scourge and a cancer and a scab on everybody who's just struggling. I mean, I had to retire to be able to go to school. There were so many people that were going to school and they had to work a second job and had kids, and they were in school and they were asleep.
Oh, I worked 12 hours at night, and then I had to do 12-hour clinicals too. So on Saturdays in my second to last semester of nursing school, I was up 24 hours a day because I had to work, because I had to pay my rent to get to get through nursing school. I didn't get to stay at home. But I agree with you, because the thing is, it's not about the board certification. For everyone watching, we're not complaining saying we don't want to be certified. We shouldn't have to go.
Right. Exactly.
I shouldn't have to pay you
Yeah.
go through this. I'm paying $400 for this exam. I just paid $300 for my public health nurse certification. I have to pay $290 to the Board of Registered Nursing to renew my nursing license this year. So right now I've come out of close to $1,000.
Because it's a commodity.
for all
It's
of
a
these-
commodity.
Yeah, so
for
people are
sale.
making money off of us needing these certifications, and we need them. These also factor into quality measures and things like Ron was just saying. But at the same time, going back to us being pinched, the providers on the provider side, we get pinched too with these certifications and things like that. Right. I didn't mean to go into this conversation. I was just making a little funny joke because I am studying for it, but it is true. Like now that I think about it, yeah, I'm going to pay about $1,000 in just certifications and licensures this year. That money could have gone to something else. Oh, like, I don't know, I'm a millennial and I should be probably saving for that thing. What is that thing called again? Retirement?
Yeah, if you're lucky enough to have it.
Oh, that's not going to exist when I get there. I'm not even looking toward it.
Well, and that's what we have to fight for. We have to fight for so many of these things, and it has to be
AB1400.
Yeah.
Well,
that's what, and that's
but
what,
also the caring, gross domestic caring that we pay for people to go to school. We pay for people to work as caregivers, and by that I mean to say we pay them enough so that they have a decent house, they live in a community, they have time off, so they can contribute to the community. They're not working more than, we should be working 4 to 6 hours a day, not 8 or 10 or 12 hours. I never understood how 12 hours shifts freed you. You know, I get an extra day off. It's like, no, you don't. You're exhausted on the 5th day.
so I will then bring us to a close in saying that by sharing an opinion. And my opinion is that AB 1400 would be transformative in ways that would change healthcare from being a commodity in the state of California. And so for that, I thank you for your contributions, Michael, and thank everybody who joined us today, particularly Jedi Gina. So this amazing co-host. Such a pleasure to do this with you. But to everybody here who gives to this, and we'll be back next week. I know Paul Hicks out there, Randy Hicks, you had a question, which maybe we'll hit it next week, which is what happens to fee for service. But I think we're out of time now. There's pretty clear answers to that. And we will, but we'll be back at 5 p.m. next Sunday, as we have been 21 weeks in a row. So we'll see you for number 22, and have a good evening.
And may the force be with you.
And may the force.
Bye, everyone.
Thank you, Paul, too, for all your good work.